This retrospective cohort study, conducted by Luo and colleagues, examines risk factors for adverse outcomes in step-down oral antibiotic therapy for uncomplicated gram-negative bacteremia. Analyzing data from 9,164 patients treated between 2018 and 2022 at Kaiser Permanente, Northern California, the study provides insights into optimizing treatment strategies. Gram-negative bacteremia is a significant hospital concern, often stemming from urinary and gastrointestinal sources, with Escherichia coli and Klebsiella pneumoniae as common pathogens. Emerging evidence suggests transitioning to oral antibiotics post-stabilization offers similar outcomes to prolonged intravenous therapy, with benefits like shorter hospital stays. This study aims to compare 90-day outcomes between complete intravenous and step-down oral antibiotic groups. The study design involved a retrospective cohort of Kaiser Permanente Northern California adults from January 2018 to December 2022. After applying exclusions, patients were stratified into continuous intravenous and step-down oral groups. Of 23,512 identified gram-negative bacteria cases, 9,164 met inclusion criteria. Notably, 90.2% received step-down oral therapy, while 901 continued intravenous antibiotics through outpatient parenteral antimicrobial therapy. In our cohort of 9,164 patients, CIV patients were generally sicker, with higher intensive care unit admissions and comorbidity burdens. The median age was slightly younger in the CIV group at 70 years, compared to 72 in SDO. E. coli was the most common pathogen, but Pseudomonas and Serratia were more prevalent in the CIV group, indicating more resistant infections. The 90-day follow-up results show no significant difference in all-cause mortality between continuous intravenous and single daily oral groups. However, single daily oral therapy significantly reduced all-cause readmission and recurrent gram-negative bacteremia rates compared to continuous intravenous. The higher readmission rate in the continuous intravenous group likely reflects a greater comorbidity burden rather than the antibiotic route. Fluoroquinolones, due to their high oral bioavailability, show a significantly lower GNB recurrence rate of 1.55% compared to beta-lactams at 3.20%. Third-generation cephalosporins have a recurrence rate of 2.56%, while first-generation cephalosporins are at 3.97%. The role of oral beta-lactams requires further investigation. Independent risk factors for adverse outcomes include male sex, high Charlson comorbidity index, and cancer. Step-down oral is as effective as continuous intravenous with no significant mortality difference. Charlson comorbidity index is the strongest predictor of negative outcomes. Fluoroquinolones are preferred for step-down oral due to lower recurrence rates. Further research is needed on antibiotic duration and step-down regimens.